All right, and welcome to chapter 7, mini number 5, the hip. This one is going to be the big one and the most involved. Let's go ahead and play the slideshow. Give my little laser pointer. All right, so the hip. The hip joint is classified as a synovial type, and it has a large fibrous capsule that contains synovial fluid. It is freely movable, or diarthrodial is what freely movable means, and it is the truest example of a ball and socket movement type. So the head of the femur forms more than half of a spear as it fits inside of the cup-shaped acetabulum. Acetabulum is what is part of the pelvis, and this is where the femur sits inside of it. So movements of the hip joint include flexion and extension, abduction and adduction, medial and lateral rotations, and circumduction. So here's looking at a pelvis. This is where your acetabulum is, right there in the bony part of the pelvis. This is the head of the femur. And this is showing anatomic position, which is true of the knee, the leg, and the ankle, but not of the hip. All right, remember our hip actually has a little bit of an angulation towards the anterior, so towards the front. You see that there. We have to compensate for that angulation. And this is how we know, based on the x-rays, where the leg is in position. So if your foot is internally okay, so this is the right hip and leg. This is an internal rotation of a true AP of the hip. All right, the greater trochanter is out, and you don't see the lesser trochanter. But when your right foot is out, externally rotated, then you can see the lesser trochanter, both of them. So we know that you didn't put your foot in the right position if we see the lesser trochanters. Here's your feet in anatomical position, right? Straight up and down. So this is what the pelvis would look like without correction of the lower limbs. You can see there the greater and the lesser trochanters. So here is where you immediately rotate the feet inwards about 15 to 20 degrees. And when you do that, you are placing everything in that 15 to 20 degree alignment. And the lesser trochanters on the inside here, they slip away and into where you can't see them. You can just barely see them on the outside, but it's not as pronounced as this one right here. Okay. So here is an external rotation when you have the feet parted and externally rotated. Your greater trochanters come up and over, and you see the lesser trochanters in greater profile. And here you can see a nice fracture of the pubic rami. So here's what we were talking about is a typical of a hip fracture. All right. A person's foot will usually be rotated outwards. They will not be able to move their leg. And it may be longer or shorter in this case than the other leg. Right here, I can see that this side is up just a little bit, but that's understandable in comparison. But here we can see the femoral head right here. Here we can see the femoral head, but the entire femur has broken off and has rode upwards and shoved itself up over the femoral head. Yeah, that's going to require a surgical intervention. So, what we need to remember is the exposure factors and patient dose. To reduce the total radiation dose to the patient, a higher KVP range of 80 to 90 is used for a hip and pelvis. Um, Higher KVP, however, decreases the contrast and may not be advisable, especially for older patients who have lost a lot of bone mass or bone density. Um, and this is where we're going to start getting into the KVP and start thinking about these things. Because if you have an older patient who has osteoporosis with a fracture, they may require even lower KVP than average. Overexposure with high KVP on osteoporotic patients will decrease the visibility of the bony detail when using both analog and digital systems. Okay, so this is where we're going to have to start playing um, guessing games about, okay, if I normally do a hip in 80 and I have this very tiny patient who obviously has a hip fracture, I might want to do 60, you know? Um, and just go from there and see what I get with. Otherwise, you might burn through the entire bone entirely. So here is an AP pelvis. Now, an AP pelvis is usually routine with most singular hips, and it's definitely ordered with bilateral hips. There is a CPT code for a pelvis alone. There is a CPT code for a bilateral hips and pelvis. And then there is a CPT code for a singular hip. A patient can come in with a left hip x ray. Now, in most places, they require you to do a pelvis with that hip. You are not doing anything illegal or against the law. That is what is called the standing protocols for your particular organization. And the reason for that is if I didn't see the entire pelvis and I only did one hip, okay, what if they had a fracture on the other side? They get the entire pelvis so that we can see both sides of the pelvis and see what's going on. So we're going to learn a lot about the different projections that are required to get hip x-rays. Now, a lot of these are trauma or trauma modified views. You will have some walkie-talkie patients who can do what we need to have them to do, but a lot of patients won't. And a lot of your patients will not be able to do a Denalius Miller or a Cleaves method or, roll over on their stomach, things of that nature. So you're going to have to become experienced with how you can make it work with what your patient can do. All right, so we're going to go over this in positioning, and I'm sure you already have, but this is called a frog leg, but you need to be aware that it's called a modified Cleaves method. All right, your KVP range doesn't change between the pelvis or the hip, so you can keep on the same technique all the way through, unless, of course, you're dealing with an osteoporotic person. So I'm not going to read you all this, but here's the part positioning because I want to show you the picture. Ooh, the picture. All right, so here is our modified Cleaves method. Here is an ovarian shield in place, and man, they really perfect. I don't know how anybody would manage to get a thing that perfect, but please don't shield your patients because being right here, you're more than likely going to get it into the way of any anatomy that we need to see. So what they do is they lay them down, they abduct, meaning they turn the legs out, the femora, and you can see on the insert here, they usually ask to put your feet together, bring your knees up, and let them relax out. All right, and then you get this lovely little picture of frog legs. And frog legs are fun to do, but it's just when your patient can't do a frog leg, then you have to start thinking of the other things that you can do. So this will show no rotation because you need to have these two bones at the same to look like they're in alignment here. Have the entire pelvis on the x-ray. Now, because you have your legs up at this angle, the x-ray divergent beam is shooting out this way. You're going to foreshorten, which means make it shorter, your femora, okay? we are aware of this. Oops, we moved beyond. Um, you won't be able to see a fracture down lower. And if you suspect something, then care needs to be taken with your patient. And you're going to have to get x rays lower than this. This is just a quick view of the modified Cleaves method to take a look at the pelvic brim, the obturator foramen, the pubic rami, but you can't really see the trochanters, but you can see it right here on the top. If you had a fracture right here or a fracture right here, that might actually obscure it. So this is mostly done for patients who are walkie-talkie and can do. So an AP unilateral hip, do not attempt to rotate the legs if a fracture is suspected. You're supposed to do an AP pelvis projection to include both hips for comparison before an AP unilateral hip is performed for possible hip or pelvis trauma. So your ranges are about the same. An AP hip is going to be the exact same thing as doing a pelvis just under the hip part. Okay. The foot's going to need to be rotated in about 15 to 20 degrees. And this is where I'm going to come out and say I highlighted it. Any existing orthopedic appliance should be visible in its entirety. And the collimated field should demonstrate the entire hip joint and any orthopedic appliance. So this is just, if you thought about it, if you had a perfect setup for a perfect hip, all you really need to do is come down about 2 inches, right? Because you're going to center your pelvis right about here. You're going to come over and come down. That's where you're going to be. That's where you're going to center, is right about there. You don't even need to move. You don't have to move anything. Here's an AP hip. Here's the greater trochanter. Here's the lesser trochanter. Very nice view. I would say you need to include as much of this as possible. Please do not collimate to right here. That's not an AP hip. An AP hip should go all the way at least over to the pubic symphysis and should include a good part of the sacrum and the ala of the ilium. So here is an AP hip showing the full prosthesis for a hip replacement. So this one is a unilateral frog leg, which is a modified Cleaves. Again, do not attempt this position on a patient with potential hip fracture or destructive hip disease because it could result in displacement. We would then do traumalateral views on that person. So for a modified Cleaves frog leg, here's what we're going to do. You flex the knee and the hip on the affected side as shown with the sole of the foot against the opposite leg. Let me see if I had the picture of that. No, I didn't have a picture of the modified Cleaves. Anyways, and then you just ask them to rotate their leg out, all right? And as far as they can get it. Then you take a picture right then and there. So here is the one side of the unilateral frog leg, which is 20 to 30 degrees abducted, okay? Here is your ASIS, and here is your position. Looks very pretty. Here's one. I think it probably could have been abducted out more, but. So here is a version called the Lostine-Hickey method. And this, okay, so take a look at the person laying down. It's almost like a modified Cleaves, but not quite, all right? This one, it results in significant foreshortening of the femur region. So that's why nobody really likes to do it much. Here is the Clements-Nakayama method, and you need to know this. It is So we have the modified one for trauma, and then we have the non-trauma. Okay. This is a same thing, SID, same KVP range. Uh, Here's all the part positioning. I know I can sit here and say, put the leg in neutral position, rest the IR on the extended Bucky tray. It helps for me to show you this. So here's the extended Bucky tray, right? They've put some sandbags behind it to hold up the plate. Here is the tube. This tube is shooting through here, and I'm glad they put it with tape. We're aiming here. Here's our line, and here is, but it doesn't look like it lines up. God bless them for trying. Let me show you what the x-ray looks like. This is what it looks like. Now, because you had so much OID on it, that's why it's magnified a little bit. And it blows it up and it shows it very pretty right here. I mean, I was cutting it kind of close, but it's a very, very pretty picture. And that is the Clements-Nakayama method. Essentially, you didn't even have to do anything to your patient. You move the room, you move the table. And remember, this is the plate part to alignment. These are all the things that need to happen. So this is, we're going to go over the Donnellus-Miller, and you do need to know this. This is a common projection for trauma, post-surgical, and surgery patients. Also for the patients who cannot move or rotate for a frog leg. And so this is the one that can be done on a stretcher or the bedside if the patient can't move. The patient is laying down, and you've got to elevate the pelvis about 1 to 2 inches if possible. So if you think about it, we can raise the bed, we can lower the bed, and I'm talking about a stretcher. Or we can raise the bed in the room, lower the bed in the room if you have a tube head that can come around. So I'm going to tell you this right now. Do not place the leg on the collimator or the x-ray tube due to risk of burns or electrical shock. Back in the old days, yes, people did this, and we should not do this. We should use a cassette holder if available, and or sandbags to hold the image receptor and the grid in place. So let me show you what a Donnellus-Miller looks like. It looks like the Clements-Nakayama just a little bit, but here you put the IR plate way up here past the iliac crest. Now this leg gets in the way, and that's why they were saying please don't place it on the IR tube, because you're shooting a cross table beam directly at that neck of the femur. So we usually just hold it up, put it on the side of the bed, ask the patient if they can hold up their leg, whatever we got to do. But this is a trauma view, a Donnellus-Miller, because let's just say that femur is broken, and we need to take a cross table hip. So here's looking at it in figure form. The radiation is going to go this way, pass directly through the neck of the femur, and then right up there on the IR. Now, I know it looks a little weird, but your IR plate has to be like this, not parallel to the femur. You're making your IR plate parallel to the neck of the femur. Did I say that wrong? We don't want it parallel to the long way of the femur. We want it parallel to the neck of the femur, which is right here. So this line and this IR plate are parallel to each other. This radiation is perpendicular, and it's going to shoot right through it. Okay? So here's a picture of a Donnellus-Miller. It makes a very pretty picture because it blows it up just a little bit due to the OID. Here, sometimes this is maybe as best as you can get because of whatever you have in the way. If it's during surgery, if it's post surgical, you just do the best you can, because I can still barely see that joint space right there. Okay. What the physicians want to see is the head of the neck. All right. Because this is the post surgical one, where they've come in and here was the fracture and they've come in and screwed it all together. That's actually 1 year post op. This x ray itself would actually need additional views to show the end of the plate. Oh, and that's it. Yay.